Okay, guys, I would like to talk about both external intercostal muscles and internal intercostal muscles. And then I would like to talk something about abdominal muscles. So first, let's talk about the functions of intercostal muscles. Then we will lay our foundations from there. So we have internal intercostal muscles, and then we also have external intercostal muscles. Internal intercostal muscles are used for forced expiration. Remember I with E. And then external intercostals, um, it helps with forced inspiration. Again, I remember that with E versus I, just opposite, right? Whereas, as we all know, we need abdominal muscles for forced expiration. Now, if the abdominals are not there, for example, if you have a patient with T6, they don't have the abdominal muscles because abdominal levels are what? T5 to T12, or you can say T6 to T10. So a T5 patient or T6 patient, they don't have the abdominals, so they will have hard time to cough out the secretions, right? That's where we physical therapists come into play. We'll talk about that manual assistive coughing versus self-assisted coughing later. But let's talk about the abdominal muscles, right? If you don't, so what the abdominal muscles do is that those rectus femoris muscles, if it is paralyzed, right, then it brings the diaphragm down. So in other words, if you have active abdominal muscles, it pushes the diaphragm into a dome-shaped position, right, like this. Now, if the abdominal muscles or the rectus femoris, those rectus muscles, rectus abdominis muscles, if those are paralyzed, those so the diaphragm loses its resting position. So it starts from here. Okay, instead of being in a dome-shaped position, it flattens out a little bit. So in other words, every time you do inspiration, the diaphragm flattens out. And when you do expiration, the diaphragm passively recoils back. Every time you do inspiration, the diaphragm flattens. But then when you do expiration, the diaphragm uh, passively recoils back to its resting position, right? And this is your rectus femoris. These are your rectus muscles, right? Those rectus abdominis muscles, those abdominal muscles. These are rectus abdominal muscles. Pretty much forces the diaphragm to be in a dome-shaped position. So if those rectus muscles are weak, diaphragm automatically flattens, like not fully flattens, but it actually loses its resting shape. It loses its dome-shaped position. So every time you inspire, it starts from here and then it goes back and it possibly goes back here. If you have paralyzed abdominal muscles, you inspire, it flattens here and then passively recalls back. Whereas if you have an intact abdominal muscles, when you inspire, it flattens out. When you expire, it goes all the way up, all the way back, because those rectus abdominal muscles, they're pushing the diaphragms up in a dome-shaped position. Anyways, now let's talk about the real thing. Why do we have to know this? Because if you don't have those abdominal muscles, you won't be able to, you'll have decreased forced expiratory volume, right? Because you won't be able to cough out the secretions, right? So just remember, patient, what is the highest level of spinal cord injury where a patient can independently independently do assisted coughing? Which is the highest level of spinal cord injury that a patient can do self-assisted coughing or independent manual coughing without needing anyone's help? It is at C6, and as we know, as we have lower level of spinal cord injury like C7, C8, C9, you have obviously the patient will be able to independently release a cough by himself. But C6 is the highest level of spinal cord injury where a patient can independently self-assist. Uh, they can self-assist themselves to release the cough by themselves without needing anyone's help. In other words, at C5, patient would need someone to manually assist them to release the cough. right? And just remember the intercostal muscles that I just mentioned, internal intercostals and external intercostals. All those intercostal muscles are innervated from T1 to T11. So if a patient has T6 paralysis, or if patient have T6 spinal cord injury, yes, they will have ineffective cough. They will have hard time uh, to do effective coughing, because why? They don't have the abdominals, obviously. But then they do have the intercostal muscles, because intercostal muscles are innervating from T1 to T11, right? So they will have, for example, external intercostals, for example, internal intercostal muscles. They will help a little bit. Partially, they will have, internal intercostal muscles will partially help to do expiration, right? Even though they don't have the abdominals, because internal intercostals and external intercostals are innervated from T1 to T11. You see? So this is one side. And how do you do, like as a physical therapist, how do you manually assist coughing? You All this for as far as spinal cord injury patient is concerned, they have to be in supine position whenever we do manually assisted coughing. So we press upward and inward from the epigastric position. So you start here, right? You do inward and out, sorry, upward and inward pressing to do manually assisted coughing. Inward, sorry, upward and inward, upward and inward, upward and inward. And when do you do manually assisted? Like when you do, like when do you manually assist to release the cough? When the patient is expirating, when the patient is doing expiration, that's when you manually assist. That's when you manually assist them to get the cough out.